today that we are able to have our World Blood Donor Symposium. It is a long time coming. We celebrate the World Blood Donor Day on the 14th of June every year. And we in Kenya have a whole week of World Blood Donor Day. Today, the theme of this year of 2021 is Give Blood, Keep the World Beating. And I hope each and every one of us is able to donate blood today. Every unit of blood donated actually helps more than 4 people because we prepare different components. So we'll start off right away. I see in attendance is more than 350 people, and I'm grateful that you've all taken time to come in and join us. I have a very exciting group of panelists who will introduce themselves even as I give them a few minutes to tell us something this afternoon. We'll be concentrating mostly on the blood donation service and also the testing of the TTI infections. So our first speaker is Philip Nyabera, CEO of Lifebank Limited, and will be able to give us some few tidbits in terms of his experience in Kenya and even our partnerships, growing our partnerships with the county, with our county facilities. Karibu sana, Mr. Philip.
Good afternoon, everyone. I hope you can see me. Okay, I hope you can hear me. Okay, my name is Philip Nyabera. I'm the country manager and CEO for Lifebank Kenya, and I'm really thrilled to be here today to be on a panel that will be discussing a lot of good things in terms of blood donation and a lot of efforts that has gone into that. And I'll really take more time during my presentation, take you through what we do at Lifebank. And thank you all for joining and looking forward to a great discussion. Thank you.
Go ahead, Philip, with the presentation. Thank you. Philip, please go ahead.
Okay, sharing my screen shortly. Let me start. So I'm going to talk about sustainable partnership and how they are affecting blood donations and the blood ecosystem at large. So let me just share my screen for a moment. Okay, I hope everyone can see my screen now. Can you see it, Dr. Chege?
Yes, we can see. Thank you.
Thank you. So I'll be talking about sustainable partnership in the blood ecosystem. And this is quite elaborate because we need a lot of synergies and partnership in this ecosystem so that we can be able to achieve blood sufficiency and availability whenever needed. So I'll just be taking you through what we do as Lifebank first of all, then I'll go through the rest of the presentation. So at Lifebank, what we do is we are a medical distribution platform connecting doctors and nurses with doctors and nurses to medical supplies that they need at the right time, delivered in the right condition, faster and cheaper and safer than most of the alternatives available. So basically what we do, we deal with medical supplies like blood, oxygen, consumables and all that. But today we are really focusing on blood because topic basically is on World Blood Donor Day, and like just basically take you through what key partnership in this field entails and how we can be able to scale using the different partnerships we can be able to make and make sure that blood donations and blood transfusion is quite key and essential for every patient who requires it. So I'll go through the challenges that we face as a country. So blood is essential for for every healthcare system to function. And it's critical that because many medical procedures depend on it, and it's quite that increased affordability and accessibility and the safety of blood, it improves health outcomes for most of the and reduces mortalities for most of the healthcare system and even patients who go through these healthcare facilities. So one thing I need to reiterate is that in every 10 minutes, we always need 7 units of blood in the country currently. And due to an acute shortage of this commodity, we always end up either losing lives and we are not able to save these lives. So the critical thing that we need to do and make sure that we manage these gaps is there are 3 key things that we need to be able to work in, and that is making sure that we have accessible units of blood that can be able to save this life. We need to ensure safety of the same, and we also need to make sure that affordability of this commodity is actually made possible for every person across the economic scales, both in the private sector and the public sector as well. So the key partnership areas that I'm currently looking at is this, that most of the time in Kenya, we've really depended on donor funding in terms of pulling through a lot of things, in terms of setting up institutions, setting up key things in terms of blood and blood transfusion. So we are looking at ways in which, as local partners, we can be able to come together and make sure that this sustainability enables everyone within the ecosystem to be able to coexist with a sustainable model that will work for all. So the challenges in the blood ecosystem have been reported for the longest time, and it's very imperative that all of us give solutions to address these issues. And this will enable us to be able to cope with the emerging trends in terms of blood needs, and also we are able to prepare for future emergencies that might come through key and strategic partnership that we may look at. So the key interventions include the blood collection centers and smart banking, that's blood banking. Then we look at donor mobilization, and we look at blood drive resource mobilization. So as you can see, on Monday was a World Blood Donor Day, and a lot of people turned up to donate blood. And that is the key thing in terms of making sure that we keep this world beating by allowing other people to donate for those people who cannot be able to. So for us to save the lives of those people who cannot be able to have this precious commodity available to them. So as you can see, there are some people that are donating blood, and also we have a poster here that is calling people to action to go and donate. And I think currently, today being the 16th, people are still at bomb blast, and at Mama Lucy Kibaki Hospital, they're still giving blood. So if you're on this call and you have not heeded to that call, please do after this. You can always join in and also be part of the solution in terms of making sure that we have a sustainable blood ecosystem. Then, so I just want to talk about the key partnership components in terms of how we need as stakeholders in this business and as in this ecosystem, and also as stakeholders who currently have either friends, we have family members out there who are in hospital and are not able to access this. How can we be able to, as all stakeholders, come together and form a good partnership that can be able to make sure that everyone gets this commodity and gets blood at the required time, at the right condition, and safer than most of the alternatives out there. So I think number one is just develop a strategic partnership plan where we estimate the resources required, we estimate the key roles in terms of which partner takes what, outline the partner selection criteria, and how we are able to just make sure that everyone engages through the different strategies to make sure that we achieve the collective goal. So the other thing is also investing in the program. We align the staff, we develop staff training, and make sure that everyone who is taking part into this partnership understands what we need to do and where the money is coming from, and also we are able to provide resources that are able to make sure that everyone taking care of this partnership is well aligned, so that we don't have any gaps in the future. Then we have a faster collaborative culture. So we're able to establish leadership support. We provide program visibility, and this will be able to establish a common language and also promote ongoing communication for any other changes or contingencies to be made. Then we market the program, because we have different partners in this place. So we have partners like donors, number one. We have partners like people who work, the private sector players who work in this ecosystem. Then we have government players who work in this same ecosystem. And then we have now the hospital teams and now the patients and the general public who now consume this. So we are all able to market the importance of this to them and make sure that they understand how this important commodity affects their lives, and we are able to engage them thoroughly and make them understand how partnership allows for people to be able to come together and make a common goal be achieved. Then lastly, we measure progress. So after having all this done, we're always coming together to measure progress of how these partnerships have grown and how they are able to change each and everyone's life in the future. So I'll highlight some of the partnerships we've done with the different partners in government and private sector. So I'll start with Smart Bank. This is one thing that we have done as Lifebank Kenya. And this is one of the sustainable models that we are trying to adopt to make sure that the blood ecosystem really works. And this is currently being taken down to the counties through the devolution of the different functions that are currently being devolved through the health department and the Ministry of Health through KNBTS as well. So I'll take you through the Smart Bank. So the Smart Bank basically is a smart bar bank that allows people to have three components. So number one component is basically collection of blood. It allows for people to come in and they're able to donate blood. So the blood is collected, then sent to a center for screening. The next available KNBTS screening center that can be in the regions, or if it's in Nairobi, to their main testing centers. Then the other part is that it does banking. So once the results come back, the blood is banked at the center. And lastly, it's coupled with last mile delivery. So with this, it allows for any person within that locality or that catchment area to be able to get this blood without delays and at the right time it's required. So this Smart Bank was born through a partnership with KNBTS, NMS, and Lifebank, and it was launched in May, and it has really changed the landscape in terms of how what the problem was and how we have impacted that to the current trends currently. So I will take you through the components of it and also just touch base on what we are currently doing with the different partners to make sure that this is also scaled to the rest of the regions. So this is how it looks. So it has an office section and it has a lab section. So the office section basically is where we have the technology based. This technology allows for donors to be managed. It allows for the banking to be done. So it gives an inventory of all the units that are available within the bank, and it gives it's also used to dispatch the different units to the different hospitals or healthcare facilities within the jurisdiction that it has been assigned. So this is how it looks outside and how it's branded, just to make sure that it appeals to the general donors who are able to come in and they are able to donate for their loved ones, donate for the people some of them even come voluntarily, just donate for the people who they don't know, which is a very worthy cause, and we really laud the efforts. So I'd just like us to have a short time to listen to this video and see what's happening. Sorry for that. Yeah, so basically that's how the smart bank works. Then the other part in terms of collaborations is donors and donor mobilization. So you find that without donors or without us having to mobilize donors, you find that we can always have very good investments made. But now those investments can only work once we have people coming in and donating blood for a worthy cause. So you know that like currently we always have this notion where people only donate for family and friends, and which is not quite very sustainable. But we always call to action for voluntary donors just to come in and donate and save that life that did not, maybe some people don't have families closer that can be able to donate to them for them. So you find that they end up not really getting the help they require because we all have either decided to only donate for families. So the only way to make sure that this is sustainable and make sure that every patient gets a pint they require is that we make sure that we have a network of voluntary blood donors that can be able to donate blood at any given time and make sure that the ecosystem is sustainable for everyone that requires blood. They are always able to get blood. So the call to action here is just to make sure that everyone out there is sensitized of blood donation. So there are different apps out there, there are different technologies out there that are just currently working together to make sure that blood donors come into centers, come into hospitals and able to give a pint of blood so that we can be able to save life. So as Life Bank, we also have an app. It's called One Donor App. So this app allows for people to also go in. They can also create appointments to the nearest center that they can be able to donate blood, and they can always have their vitals and medical what do we call this? I think I'm missing that. It's a medical history or that captured so that the next time they just come to donate, it's a process that allows for this to seamlessly go through, and they can now be able to donate as voluntary donors each and every single time. For men, that is 4 times, and for women, that is 3 times a year. So these collaborations in these areas allow for a lot of people to visit centers, donate blood, and make sure that blood is available for everyone that needs it at the right time. Then the other areas that also we are working on in terms of synergies with the different partners in the both private and public sector. So we have something called BOT. So BOT allows for, it's called Blood and Oxygen Trust, Access Trust. That's where the name BOT is derived from. And this is just a fund that enables people who cannot be able to pay their medical bills based on oxygen and blood. This can be able to be offset through a system that allows for doctors to verify the validity of these claims, and now board can go ahead and pay, because you've seen that some people have been locked into hospitals because they have not been able to pay. There are some people always for fundraising for funds because they were not able to pay some medical bills. But with BOT now, that makes it easier for everyone, because now there's a fund that allows for those who cannot be able to pay to access these funds, but through a process that is approved by the medical doctor. So this fund has been placed there by private sector players. So they give in some money, and this money is used to offset the different medical bills for the different patients out there. So that's how BOT works, and that's how it really helps out for people that urgently require blood and oxygen. Then I would just like to give you some of the engagements we've made over time. So we've made an engagement with NMS. So the Mama Lucy project is an engagement between KNBTS and NMS and Lifebank. Then we have other ongoing engagements with the Machakos County. We have had other engagements with the Homa Bay County and Homa Bay County as well. There is Mombasa and Kisumu County also in there. So we are currently in the talks to make sure that we have this sustainable partnerships in terms of creating more blood collection centers and smart banks, and also making sure that we can be able to use those as the tools to make sure that we have more voluntary blood donors coming through, and also making sure that this establishment help to have access to this critical blood commodity. So I think with these engagements, we will be able to get closer to the normal Mwananchi, and we are able to ask them to come with a call of action to come and donate blood for every person that requires it. So I think for me, in conclusion, I'd like to say, in today's fast-paced environment, a go-it-alone approach is not always the best strategy for growth. And companies and governments, institutions need to learn for new ways to drive collaboration, innovation that delivers on what is needed today and in the future. So for this, I think in the Kenyan blood system, we just require more partners coming together to make sure that we are able to come and create more blood collection centers, have more blood mobilization schemes. We have more donor campaigns that are calling to action everyone out there to come and donate so that we can be able to save a life together. So today I'd just like to urge everyone, we come on and let's all collaborate and save the lives of this patient and everyone in need of blood. So I think this is just a call to every partner on this call, every person on this call, that it's a time that we all need to put away any other differences and any other issues that we may have, but we come together and make sure that every patient out there gets blood at the right time, in the right condition, safe and affordable to all. So thank you all, and I really appreciate for your questions in the chat, and we'll go ahead. Thank you very much.
Okay, thank you so much, Philip, for that presentation. This is unlike the normal presentations that we are used to seeing, science and all that. It is just to show that all of us are potential partners and in terms of donors, and that was what Philip has tried to demonstrate in terms of sustainable partnerships. COVID has really affected our blood donations, our numbers and our banks. There was a time they were dry, but now with these sustained partnerships that are being cultivated across the country, we're able to have more blood in the banks available for when you're in need. As health workers, we tend to forget that we are potential donors, and we may not actually donate. I remember going somewhere and asking the group, how many of you have donated blood? And almost 90% of the room, no one raised their hand. Only a few individuals who were there who raised their hands, and they told me they donated when they were in high school. In their adult life, they've not participated in blood donation. But making sure that we have regular blood donors and truly saves lives. So thank you so much, Philip. Now we shift gears immediately, and we go to Dr. Peter. Peter Ram is a senior international medical affairs manager at the Roche Diagnostics International, working with RDS serology infectious disease, including SARS-CoV assays since August of 2019. Before that, he was responsible for coagulation, hematology, and urinalysis, and covered the RDS oncology assays. His scientific interests include the rise of new infectious disease pathogens, HCV elimination programs, and recent developments in therapies and biomarkers. He's a trained pharmacist from the University of Mainz in Germany. I hope I've said that right. And holds an MSc in pharmaceutical medicine. And he has a PhD in pharmaceutical technology from the Johann Wolfgang Goethe University in Frankfurt, Germany. So prior to joining Roche, he was working for a Danish drug company, and that is familiar to us. That's Novo Nordisk in the hemophilia franchise, Sanofi, Boots, and Boots Healthcare. He's a member of the International Society of Thrombosis and Hemostasis and International Society for Blood Transfusion. So, karibu sana, we say welcome.
Thank you very much, Dr. Shige. I'm not sure, I don't think I can activate my video. I'm not sure whether it has to, the host doesn't allow me to, but anyway, so I'll hope you can hear me well and you can see my slides already.
Yes, we can.
Okay, super. Thanks a lot, Dr. Shige. Again, thanks a lot for welcoming me to this very interesting symposium. And again, also my kudos to you, because I think your pronunciation of all the German places and my name is excellent. So definitely very great. So yeah, what I've been asked to do is talk you a little bit through aspects how blood safety can be achieved. And again, also the importance of blood transfusions. And I think a previous speaker, Philip Niavara, has also shared quite a few insights from his perspective. And I'll basically talk a little bit more general, maybe in some ways, about these things. So in fact, actually, if you look from, so maybe I should also say something a bit more about myself. So I'm actually based in Switzerland, where the Roche headquarters are. And I also work in a global function. So the elements that I share really take very much a global perspective. However, I will also try to relate it at least to Africa and to some extent when talking about certain aspects. And of course, the essays that we provide are available globally where they are approved. So generally speaking, blood transfusions are the most common hospital procedure. I think people tend to forget about this, right? People need blood all the time. And even during the pandemic, I think taking a quick relationship to COVID-19, we had put high hopes into convalescent plasma. Unfortunately, as we know now, it does not seem to work well. I mean, all the clinical trials have not shown any kind of significant improvement. So what we know now is that pure antibody cocktails do seem to work in more severe COVID cases, especially in the beginning. Yet again, just it's important to remember that still plasma and blood products overall are very much needed, not only the pure blood transfusion, which I think most people have in mind when they think about blood, right? You have an accident, you have a severe blood loss, or you have a surgery, you just get blood. No, blood is actually used to basically produce a lot of different components. So this is a bit more the Swiss perspective. I know we've also been shared the Kenyan perspective. Every 2 seconds, a blood transfusion is needed. Basically 700, basically everybody's 80% of people need a transfusion once in your life. And actually in Switzerland, we have about 770 blood transfusion needed every day. So again, 80%, again, this is more the Swiss figures, need a transfusion once in their life, but only 2.5% of people in Switzerland actually regularly give blood. So you also see here, and I think that's a global challenge, blood supply, blood transfusions are actually very hard basically to come by. And 50 minutes of giving a transfusion can actually save up to 3 lives. This is from last year's Blood Donor Day. Again, what is it used for? I understand also the audience that we have today in the symposium is very diverse. So maybe I spend a bit more time on, again, with a bit more details, what those blood products are used for. Again, the trauma, this is again the thing that I think, again, come to mind to most people. You have basically a traumatic injury, you have a blood loss, you need blood replacement. But if you look at the list, actually, that's actually the least amount. Childbirth is actually also putting women at a high risk of blood loss. But severe blood loss during childbirth is not very uncommon. And often women giving birth do need a blood transfusion of blood products to basically also reestablish coagulation functions in their system. Children, especially those having severe anemia due to malaria or malnutrition, needing basically blood replacement therapies, needing enough red blood cells, for example, to replenish the oxygen functions. So this is really, really important. Other medical problems, heart, liver, I think I could also think of bleeds, in the gut, for example, those could also be needed for blood transfusion surgeries. Again, heart surgeries were typically, or other large organ surgeries. This is also where typically blood loss is not too uncommon. High blood loss and blood transfusions are needed. Anemia. So this is actually one of the higher parts of basic blood replacement, because if you have anemia, for example, if you have an inherited disorder of hemoglobin, so this would be, for example, this would be other areas where blood transfusions are needed. And last but not least, cancer or blood diseases, bleeding disorders, thalassemia, sickle cells, blood cancers, so leukemias. This is really where the majority of the blood products go into. And having worked for quite a few years in hemophilia and rare bleeding disorders, I also understand that a lot of blood banks do also produce concentrated factor products or fresh frozen plasma to actually first line treat hemophilia patients, for example, or rare bleeding disorder patients when there is no other treatment option available, such as recombinant factors or the recently developed antibodies. This is, I think, a picture that you're very familiar with. These 50 minutes can really change quite a few lives, as we've seen. And however, this slide is threatened, and now there's a little bit of a slideshow here that basically shows you the issues that we're actually facing, because we have, and I've seen also there was a question in the chat, what happens when there is new pathogens arising. And this is just a few pictures of conditions that we're unfortunately all too familiar with. And we all have, of course, COVID-19 very much in our minds, SARS-CoV-2 virus, which has caused now 3.5 million deaths up and counting. However, we should not be forgetting about the smallpox that is estimated to have had about 300 million caused about 300 million deaths, Black Death, so the pestilence that's also called Spanish flu, about 100 million deaths, measles, AIDS, for HIV infections, still of course very important for Africa, for the African continent, subcontinent, and a lot of others. I mean, again, we shouldn't be forgetting about malaria, all these infectious diseases that are also pose a threat to blood transfusion, because what you don't want to have happening, of course, is if you have if you receive a blood transfusion, and otherwise you've been healthy before, that you actually acquire an infection through a blood transfusion. So safety is really adamant. Safety is first when it comes to blood transfusion. So, and we know also now that basically, again, when we think about killers or disease burdens, that, and this is figures from 2017, but I don't think they have changed that much. Cardiovascular diseases are still ranking top for basically the 57 million deaths that we see, but infectious diseases are already the second largest cause of death globally speaking. So this is very important to remember. So again, when we look at blood donations and blood safety, this is the risk of actually somebody very much unknown, for example, in very good faith giving a blood donation, believing he or she is healthy, then basically can still have an infectious diseases which needs to be discovered through the safety systems that we have in place. The WHO list of 10 threats to global health is also global influenza. This is not an issue with blood transfusions. However, other pathogens, Zika, Ebola, and you see here on that slide disease X, which I think we can also replace with SARS-CoV-2. Again, not an issue very much with blood donations. However, we never know what is going to happen, right? That has definitely been, the world has been taught, I think, from Africa, from the African side. I know it's a huge continent, but I think you're probably more familiar or more used to certain outbreaks in the infectious world than other regions of the world. But dengue, for example, in Latin America is also very important, or HIV, again, I mean, this is a global issue. So this is really where we have the 10 threats to global health, and this needs to be tackled. This is a slide that is more or less just giving you a bit of a perspective of other threats, right? I mean, we have global warming, and this is, of course, affecting all of us, no matter where we live. And this is just an example of mosquito spread, malaria mosquitoes, the tsetse fly that basically transmits malaria, and that basically is also getting closer and closer to the northern hemisphere and further south. So this is, as you can see here, in this animation. So it is really important to, again, to measure that and to also be aware that not only the pathogen as such, but vectors or vector-borne diseases can be carried further in different regions and the other way around. So it's not only something north-south, but also, of course, depending on the impact. I think, again, what is, for those of you who work in a blood bank, I'm sure you're very familiar with this. Blood is actually treated as a drug. And so myself, having a pharmacist background, this is something, of course, that most people maybe also not be aware of. That if you really talk about blood transfusion, this is where really you have to apply all the safety measures that apply to drugs in general. They actually also apply to blood transfusions. And basically, the blood banks are required to ensure safety by qualifying the raw material into basically medications. That's what they are. And in this way, you see here in this animation, in this way, you have a risk of transmitting a pathogen. And this, of course, should be basically avoided. So it's very important. And that's why it's important to basically do testing, do comprehensive testing of the raw material, like for any other drug, before actually applying it into another human being. So typically what happens is that testing is only performed on a limited number of infections. So also, as I said before, not all infections that we carry with us are also an issue in blood transfusions. So again, I'm just taking SARS-CoV-2 as an example. SARS-CoV-2 is an airborne virus, basically, that is, of course, can cause severe damage in our organisms. However, it is not transmitted via blood transfusions. So it's not an issue for blood bank. It's not a safety issue. However, there are plenty of others, and I'll talk to that in a minute, that basically, if you look at the basic panel. So there's, of course, the testing that is important. Another part that really is important, and Dr. Niabara also spoke about this, it's also about really screening donors, qualifying donors, looking at donor pools. So it's also about donor education and questioning, basically, a little bit about their lifestyle and in whatever appropriate form, and selecting donors that actually have a low risk of infection. And that's important, basically, and that can have all sorts of dimensions, those risks. So it depends where they, for example, live, what kind of lifestyle they lead, all sorts of things. Of course, blood donors, for example, using injectable drugs would not exactly be the optimal choice, to maybe put it that way. So examples here, a few examples. So travel to residents in a malaria endemic area. This is where it's challenging, right? So again, you don't want to transmit malaria through blood transfusion, or again, behaviors that are associated with a higher risk for blood transmittable diseases. So the big challenge, of course, and this is something that is really the key, is the window period. So between an infection and the actual development of either pathogen levels that are measurable, and we typically can do that very nicely and very sensitively with a PCR method or other nucleic acid amplifying techniques, and the development, for example, of antibodies or the rising of antigen levels, there is a window period. And the window period, of course, is then the critical issue, because during the window period, the blood that's been given is already infectious. However, the systems are not, the assays may not be sensitive enough to find that out. So the goal of anybody who's working in a blood bank, and of course of Roche being one of the providers of Roche of blood safety solutions, is to actually close down and make that window period as little, as small as possible. So this is really important. This is where the focus is also when we look at the development of our assays. So it's really very, very important that we have a very high sensitivity and we detect infections as early as possible to really avoid having a transmission through blood transfusion. So this is just a little bit what I just said. So it's also, and that's also, this part is also important to question really the donors about their lifestyle. So, and we have two basic techniques that basically come into play. We have the so-called nucleic acid tests, so they are RNA or DNA based, depending on the pathogen. And then this is basically then describing in a very simple format the developments. You have first the actual pathogen that you can find, and then you have the antibodies, and then basically you detect them with immunoassays. So this is the two big types of assays that you can use and that are also offered by Roche Blood Safety Solutions. So what has happened over the last couple of years, decades? So we have really been able to shorten that window period. So the sensitivity overall of our assays has increased. And this also means that actually finding the infectious transfusions and identifying them has become actually easier and better. And you may ask yourself, how do we actually test that? So we do that actually through certain panels and dilutions. So we actually can look at the assays, and then basically we can buy seroconvert, or there are seroconversion panels available of people that were infected, and then they were basically giving blood and providing basically samples. And with those, you can basically, of course, these people were involuntarily infected, but they were still, again, ready to provide and share their blood. And you have seroconversion panels that are well defined. And with that, basically, you can also test your assays and can improve that you are turning them more sensitive. And of course, you have then also very high. This is one element, and the other element is basically also surveillance programs and large technical and comparison studies that we run, and making sure that our assays perform well in this context. And what's also important is that we have added new tests, new agents, and basically what technology should you use. So ideally for early detection, it's important to use the NAT technology, and serology is really more for the later. So basically it really depends. So globally speaking, there are WHO recommendations on generic algorithms and what to test. And I've also seen there was a question in the chat. So are there any guidelines? I'm sure there are also Kenyan guidelines. I don't know, Dr. Shekhar, whether you will be mentioning those later on, or if there are. But again, there are also WHO recommendations, and of course ISBT, the International Society for Blood Transfusions, also provides guidances in this field. So serological screening tests recommended worldwide are typically HIV, hepatitis B surface antigen, hepatitis C, and syphilis. This is the serology assays. And then additional tests that are recommended, and that depends again, basically on the local, regional, also risk factors. HPV, HTLV, malaria, Chagas, CMV are typically, and then of course, again, also coming back to the question, what about new pathogens or maybe a pathogen that hasn't been so relevant before, but becomes more important over time or in a certain region due to an outbreak. So as you know, Roche offers quite a wide assay, a range of assays in the infectious disease field. And those, of course, can also run and would be able to run on the same instruments that you already have in that setup. So that's basically also a certain assurance. And not only Roche, but also lots of other providers, just to give you an idea, in case of emergency or urgency, we've just seen last year how fast we were actually able to provide reagents. I mean, to be honest, I was amazed, and still am, and awed by the speed and bringing out, for example, a NAT test for SARS-CoV-2 within 4 weeks after the identification of the virus. That was just a masterpiece by our colleagues in the molecular division, and the serology assay also was only coming in a couple of weeks later. So we can really, if there is a global pandemic, a global emergency, then there is really a lot of effort put in to make sure that those assays are available. I think this is really what COVID-19 has taught us. So again, what other things beyond actual certain disease prevalences are important? So it's also about better characterizing your blood donors. So ideally, connecting with your blood donors, as it was already shown, for example, through an app, is actually quite a nice way of engaging and keeping them coming back regularly. And one benefit, of course, for them can be that they're regularly tested on infectious diseases. So they actually know they are safe, they're healthy, and I think that's also an ensuring message to a blood donor. And if you have, for example, a first-time donor, you could also provide additional testing. Also, for example, if you have, for whatever reason, suddenly a donor turning positive, there is, of course, opportunity to do further workup for that patient to actually offer better access to medical care, so which is also important. This is just basically a very simple algorithm. Again, I thought I'll put that slide into my presentation today, just again for those who are not so familiar with basically testing algorithms. And you do a screening test, just whatever you would need. You have a non-reactive, then basically you release the blood transfusion. So it's all good, all fine, the normal way. That's the way we hope for. However, there may be an initial reactive reaction to a pathogen. Then also one option is, of course, to discard the blood transfusion and throw it away safely. However, if depending on the quality system, if you have an effective quality system, you could also have the option of having a false positive event. And in this case, actually, it makes a lot of sense to basically have repeat tests in a system with an effective quality system. And if then, for example, 2 repeat tests are non-reactive or negative, then you could also release basically. However, if the repeat tests are either one positive or negative or both positive, then you would really discard the transfusion and also, of course, importantly, defer the donor and also send for further confirmatory testing. And ideally, basically also provide medical care depending, so how to decide if NAT or serology or both should be used? So first question, of course, as I've also tried to give you a few examples, is the pathogen, is it infectious in blood? Again, so for example, HIV, of course, we know is easily transmittable, or hepatitis B, C, D, E, A, all easily transmittable through blood. However, for example, SARS-CoV-2 would not be. Other bacteria, prions, we've also got Alzheimer's, mad cow disease, BSE, that they are transmitted by blood. But for example, there is not always a certain evidence of flu. It seems to be so questionable if that's the case. So the issue here is also we currently do and can only do, especially in a rising of situation, it's only performed on a limited number of infections. So that's why it's so important to educate donors and also select them based on their risk profile. And so basically, how can we make sure that the donations stay safe? It's about continuous monitoring for new pathogens, especially those that may impact blood supply, education of blood donors and the public of the importance of blood supply and blood safety. So like events like World Blood Donor Day, an event like today, with a lot of people, that's amazing. I just see we have nearly 800 participants. This is really incredible, the interest, and having the relevant NAT and serology assays available, of course, that's also very, very important. With that, I'm at the end of my presentation. Thank you very much for your attention.
Thank you very much, Peter, for that exciting presentation you've given us today. You've actually given, in a nutshell, what happens right from donor selection right to the end, where we are doing the testing. And we are grateful that with Roche, we have continued to partner, and quite a number of our platforms are also on Roche. And are happy to see that it's almost similar. What happens in Swiss versus Kenya. Also for us, trauma is up there, and maternal, the PPH, yeah, the bleeding, that is also one of the leading causes of utilization of blood and blood products. We may not be testing too much in terms of the hemoglobinopathies, but as we get a more healthier population and not having our trauma and the hemorrhage that happens during childbirth happening, then we are starting to see increased rise in oncology cases, our renal cases also needing the blood, and that's why we are actually preparing more components rather than giving the whole blood, because blood is still a limited commodity.
Absolutely.
And I like that aspect you brought in, that blood is actually medicine. We don't see it that way. So it needs also to be controlled and make sure that whatever is being given is actually safe. Now, allow me to switch gears and invite Aaron Ogunde. He is the team leader at Damusasa, who do majority of our social media mobilization. And I am happy today to invite him. He is at the end-to-end blood services information management platform, which is concerned in facilitating access to safe blood and blood products to the patients. And actually, Aaron is a very friendly person if you meet him in real life. And he loves networking, meeting new friends, and working to create a change, especially in this blood ecosystem. So karibu sana, Aaron. You can share your presentation.
Thank you very much, Dr. Chege. I hope you can hear me.
Just a minute, Aaron, as you're setting up your presentation, please guys use the Q&A box. Then we'll be able to see your questions and answer them at the end. Thank you. Go ahead, Aaron. Thanks.
Thank you very much, Dr. Chege, for the introduction. As well, I want to say thank you for this opportunity to share my thoughts on behalf of Damusasa. It really means a lot to us. And I also thank the two great speakers who've gone ahead of me. And now that I'm actually thinking about it, I wish I had gone fast, because I hope I can fit the bill in terms of the interesting and enlightening presentations that they've both made. So here goes. Damusasa itself is an end-to-end blood services information management platform, and our main business is facilitating access to safe blood and blood products to patients when and where they need them. So Damusasa is built to support blood sourcing, screening and inventory management, donor relationship management, transfusion management, inter-hospital blood sourcing, and e-learning, as well as hemovigilance and reporting. However, today, my main topic of discussion is technology in the space of donor relationship management. And to better look at that, I actually thought that it would be good to start by pointing out the need, where we need about 2 million units of blood each year. And the way to better understand this is that, on one hand, 2 million is a very small number in a country of about 50 million. So you would think it should be easy to collect those units, but unfortunately, this is not the case for us, because on average, we've been collecting 30% for a very long time. Why? Then on the other hand, which is the one that patients requiring transfusions are, 2 million is a very, very big number, big enough to mean that it could actually either be me or you at any time. Now, it's interesting to note that, are Kenyans aware of this? Yes, they are. So Damusasa and other partners are currently running a digital knowledge, attitudes, and practice survey. And one of the questions is, are you aware that there are patients who urgently need a blood transfusion in order to save lives? 99% of the respondents so far have said yes. One other question is, have you ever donated blood in your lifetime? And most of the respondents said no so far. The other question is, and as the previous speaker has just said, do you think, or do you believe that at one point in the future you will need a blood donation to save your life? Again, 99% of the respondents so far have said yes. So to just put that into perspective, Kenyans do know that there are patients who need blood in order to save their lives. Most of them, even with that information, have never donated. Again, most Kenyans know that at some point in their time, they will need a blood transfusion to save their lives, yet they themselves have never donated. So the question should be, where does this unit of blood come from? However, sometimes the unfortunate bit is even with that type of information, being aware of that type of information, awareness may not necessarily be enough to elicit positive action, and such is our case. It's about time we started asking, why is it that Kenyans are aware of this information, yet we still have a deficit in terms of the units we need annually? However, the good news is that we already have some of the answers and we can piece them together in order to get the big picture. So over the recent past, there has been a great technological shift in both how we disseminate, consume, and even act on information. This has been made possible, of course, through the mobile and internet penetration. Now, one interesting thing about this technological shift is the fact that people have become more accustomed to benefits analysis. This is also the case in blood services, which, and most unfortunately for us, or rather fortunately, does not include the money incentive. So before I make a decision to do something these days, most people will ask themselves a question of what benefits is it to me? Who benefits with this action? Those are some of the questions that people ask themselves, especially when there is not a money incentive in the space. And the reason we've been able to get access to such kind of information is because of the digital transformation that we're all currently going through. So everyone is in the digital space, everyone is in the social media space, everyone has a Facebook, Twitter, WhatsApp account. And one of the biggest questions in the age that we're currently in, and especially looking at the target population who we want to go and donate, which is 16 to 65, and even out of that 16 to 65, we're mostly looking at 16 to 38, based on the data that we have, that actually go and donate more often than the other age group that is above 38. One of the biggest questions usually that needs to be answered is convenience. What is the convenience to the donor to make sure that whenever a call is made, or even without the call being made, would they make the decision to actually go and donate? One of the other big questions is, what is the immediate benefit to the donor after they donate? What are the future benefits? What are the social benefits? Is there transparency in the process? There's also a need and a growing need, a highly growing need for personalization. A donor wants to feel like they have been treated as Dr. Chege, for example. A donor wants to feel that they have been treated as Philip, for example. And there's also that growing need also amongst the donors, to feel heard, to feel that they have contributed to the blood and blood services space in one way or the other, regardless of whether they do donate or they do not actually end up donating. So as Damusasa, this is what we've recently committed to understanding, and after understanding, moving to actually provide solutions that correct that. So in terms of convenience, one of the ways we've started to look at it from a technology perspective is, if I'm a donor, one of the most convenient things for me is being able to actually go and donate, if I were to make that choice, at a nearby center. Because one of the challenges we've had, and we've gotten feedback from donors, is I don't want to move from one end of town to the other end of town to go and donate, especially if it's a voluntary decision. Well, if it's not a voluntary decision and I have a patient, a relative, a friend who's on the hospital bed on the other side of town, then it's likely that I will make that decision to travel all the way to go and donate. But we want to move, as a country, from that era of replacement donations to voluntary non-remunerated donations. So how do we get to voluntary non-remunerated donations while considering convenience, which is a very big thing for the modern day donor? So as Damusasa, we've recently launched an Android application available on Google Play Store that allows donors to actually using Google location to map out which is the nearest center in terms of kilometers where I can actually go and donate blood, if I make that decision voluntarily, which is actually a big thing based on the data that we've seen so far. Most people are actually now choosing to go next or nearby home. And you'd think that people knew there were where blood donation centers were, nearby blood donation centers were, but based on the information we have, people didn't know. So those the traditional centers that people used to know and go to. Now we have centers nearby home in the hospitals that are really coming up. And the other thing that we need to consider is personalization. So if Dr. Chege walks to a blood donation center, is she just any other random donor, or will she be recognized as Dr. Chege? So that is also a big and growing need, as I said earlier, especially in the age of technology and people being in the digital space. So as Damusasa, we've committed to actually personalize the experience of each blood donor through our platform in our Android application. So we need to be able to tell, for example, that Dr. Chege walked in the donation center today. If she donated, well and good, she gets her donation history straight on her phone. She gets her blood group straight on her phone. But most importantly, she gets the opportunity to give feedback to the donation center, which is now brings in the need to feel heard, to feel that you've made a difference. So Dr. Chege can actually provide feedback to the donation center where she says, I like this, I did not like that, change this, keep it up on this. I liked how you did your COVID prevention in terms of the procedures. Then we also need to consider the need for transparency, especially in this digital space, because once I donate blood as a donor, I need to know that that unit of blood ended up assisting someone. Okay, so how do we use technology then to make sure that there's that level of transparency enough to actually motivate the donor to come a second time because they've gone away knowing that their blood actually saved someone, willingly and truly. So as Damusasa, we've made it possible that after every donation, especially for the centers using our platform, donors are able to get or receive communication when their blood is actually utilized on a patient. And going further, we're actually working on making it possible to give the donor the opportunity to choose, as well as the patient, whether they would be willing to actually meet with each other. Because we've seen stories, especially from Canada, where the recipient actually gets the opportunity to meet the donor. And it's a beautiful story, actually, in terms of motivating and cultivating the culture of voluntary blood donation across the space, and to make sure that someone is actually doing this regularly without even being called upon. Then, of course, in the age of digital media as well, there's that need for immediate benefit, immediate satisfaction, immediate recognition. How do we fit that into the blood services space, given that that is what the current modern day thinker, the modern day donor wants? So for example, if I went and donated blood today, I would want people to know that I've done it. And that is why usually after blood donation drives, if you would go to social media, you will see people have updated their pictures of donations that they have done. So they would want immediate recognition by their peers to know that they've actually gone out and saved a life. So by and by, as we continue, the act of seen to be done something, to be doing something, the act of being seen to be doing something is actually becoming equal to actually doing it, if not greater, especially in the age of social media. So how do we also fit that, using technology in the blood donation space. So we need to make it possible for the donor as well to be able to share not only their pictures doing donations, but also their history, should they choose to, whereby we've actually seen people awarded by the cabinet secretary, such as Madam Aisha Dafala, for well over 60 donations. So can she share that history with her friends so that she can actually, in one way or the other, motivate other members of her peer to actually go out and donate? That is the power of technology right now. Then last but not least, in terms of future benefits, because the donor wants to know, in the future, if I'm making to act now and donate blood to save a life now, what are the future benefits looking like for me? And we've had various incentives. For example, the blood donor card, which when you get that card, it actually means that you can actually, when in time when you need a blood donation yourself, you can actually get the units of blood that you need. Now, unfortunately, sometimes we end up, because of the daily hassles of life, losing those cards. And here's the challenge. So I donate blood today in one corner of the country, say Kakamega, and then tomorrow I need blood in Mombasa. The challenge then becomes, if I've lost that card, how do I tell the people in Mombasa that I actually donated blood while I was in Kakamega, and by virtue of that, I do deserve to get a unit of blood, and I've lost the card? So with technology now, you can actually make sure that it's sort of a shared system of common knowledge, whereby if I donate blood in Kakamega, the people in Mombasa can be able to tell that I actually did donate blood. And that's what we've also done as Damusasa. We've made it possible such that if I donate in Kakamega, the people in Mombasa can tell that I donated, whether or not the donation was successful, even whether I was deferred, whether I was referred to secondary care. All that information can actually be told on using technology. And with that, I'd actually like to bring to a halt, and looking forward to your questions, and hopefully I can give satisfactory answers to all of them. Thank you very much, Dr. Chege. Back to you.
Thank you so much, Aaron, for that presentation. I see quite a number of people are writing in the chat box, in asking some of these questions. Is there a conflict of interest between Life Bank and Damusasa? I will allow you and Philip to answer in the end. Think about that as well. And let us all realize that 812 of us who've actually joined in and logged in on this particular, for this particular webinar, are all potential donors. I look at people and I go like, with 1 unit, you've helped 4 people. Now, if you mobilize, you come to your nearest collection center, which may be not necessarily the regional banks. And now we are trying to move away from hospital setups because, like Aaron said, it's a matter of convenience. We don't want to come to the hospital to donate blood. First, there are sick patients there, then you want to do it in a friendly manner, in a place that is nearer you. And some of the times, hospitals tend to be not so near our residential areas, or even our normal places where we usually visit. So you have to, I see like somebody from Kasarani. I use Nairobi as an example because it's where I am familiar with. Where you come from Kasarani, take a public vehicle into town, and then connect again, come to the Upper Hill area. So that is not convenient. If I put up a collection center in CBD, while you are coming to do XYZ, you pass by through the collection center, donate your blood, you're given a refreshment. Once they see and assess you're fine, you can continue with your day. There's no extra inconvenience to your part. So we are hearing you, and that's why we partner with Damusasas and the Life Banks and such organizations to give us a feedback that we may not be able to get to or access. Because now using that, then we are able then to change how we do our things. Now I am joined by Dr. Dixon Chana, who is actually our last speaker for this afternoon, even as we draw to the end of this. And I'm sure a majority of you are actually going to go to your nearest collection center across the country. We are across the country. We are just not in Nairobi or in Mombasa or Kisumu. We have come down even to Isiolo, even to Bungoma, we are there. So there is no excuse why nobody should donate some blood. And I use Kakamega because Dr. Dixon is actually from Kakamega County. He's the county pathologist there at Kakamega, and he's the head of blood transfusion in Kakamega County, and is currently the deputy medical superintendent in the Kakamega County General Hospital. So, karibu sana daktari. You can share your screen if you have your presentation. And then after this, guys, keep on putting your questions in the chat box. We are seeing them. As Daktari is getting ready, perhaps I can answer one. But rumors have it that blood is sold very expensive to needy patients, yet it was donated free of charge. How true is that? Blood is expensive. Like Peter had said, blood is medicine, but doesn't mean the blood that we are given freely must be tested. Must, by the time it's been transfused into a patient, must be transported from that collection facility to the transfusion facility. So there are little costs that go into this. And we were doing some comparable studies where in the private sector, you'd find maybe 1 unit of blood by the time it is tested and seen to be safe for use. In some places cost about 50,000, while in the government facility may cost about 700 to 10,000 shillings, because every single bit of it, every single step to make sure that it's safe, we must realize that we must also cost for those the costs. So there are overheads that need to be met, and that's why as Kenya National Blood Transfusion Service, we are saying give us the cost of testing, because with the good platforms that we are using, we are able to do testing for quite a number of samples and making sure that the turnaround time for the results is within the shortest time possible. And then we are able to give you, be it somebody who is in Kakamega, for example, or in Isiolo or in Kwale, they're able to receive their results in a timely manner, and then that blood that is there is given is easily accessible. I've seen somebody also ask about the issue about giving blood directly without testing. No blood in this country can be transfused into a patient without testing. If it's happening, those are some of the gaps that had been mentioned earlier that we are having a problem with. But with the surveillance and the monitoring we are doing, no transfusing. And if any facility is found to be actually transfusing without testing, those facilities actually can be shut down. So Dr. if you're ready, please let's go ahead. Thank you.
Yeah. Good morning. Good afternoon, everyone. Doctor, are you projecting for me?
You'd like I project?
I'm trying to share and it's not picking.
Okay. Are you able to share now, Dr. Ri?
It's taking me through many procedures.
Okay. Let me share the screen.
You can share yours and then I'll just read from there.
Okay, that's okay.
Good afternoon, everyone. My name is Dr. Dickson Mchana. I'm a consultant pathologist for Kakamega County, head of Kakamega Blood Transfusion Unit, Deputy Medical Superintendent, Kakamega County General Hospital, and currently the acting medical superintendent. I have a brief presentation titled Safe Blood in the County, the Kakamega Experience. Next. Yeah, so we've had a long journey which started way back in 2013 since the advent of the devolved system of governance. And in March 2014, His Excellency the Governor for Kakamega County, Honorable Paranya, met all consultants in March 2014, and he requested proposals from all of us on how to improve healthcare delivery. So I managed to come up with 3 proposals, of which one was on blood transfusion, which I titled System Strengthening and Improvement of the Kakamega Satellite Blood Transfusion Center. This one I handed in to the county minister, what you call CECM, in May 2014. And basically it outlined how we were going to partner between Kakamega County, the National Blood Transfusion Service, and an NGO, a partner known as Regional Society for Blood Transfusion. Those who have lived long enough, probably you had heard of them. And this was informed by the fact that then NBTS was under the PEFA 2. And having been in many consultative meetings, we felt that we knew that PEFA 2 was coming to an end, and counties needed to come up with sustainable mechanisms of continuing the programs therein. And in our proposal, we had suggested that the county and the national partner in an increasing ratio. So year 1, the county was to do 60, national does 40 support, financial support, HR, any budgetary support in a ratio 70, 30, 80, 20, 90, till at the end of that 3-year program, at the end of the 5-year program, the unit was to be reliant totally on the county funding, but with the technical support from the national government. So our first budget of Kenya shillings 21 million, I presented to the cabinet, and it was approved for implementation in the financial year 2015-2016. And what we had proposed in that budget was first to rehabilitate the old satellite building, purchase 2 large capacity fridges, each holding 700 pints. Why 2 is we needed to separate between screen and unscreen, because when you go to some facilities, you find they mix, and it's easy for someone to pick an unscreen unit and dispense to a patient. And then we also proposed to purchase a semi-automated screening machine. Remember, this was a satellite, and there was a lot of delays. We had technologies, and we felt with an equipment, proper reagents and consumables, it will reduce the waiting time, because procedures like exchange transfusion could not be done then. And then we also catered for support for blood donor campaign, that is refreshments, campaigns, branding. And this was approved for the financial year 2015-2016. Next, Doc. So when the money was approved, the implementation became very tricky. Actually, I describe it as rocky because the then leadership at NBTS wanted the money taken back to the national government, and then they align it to their plans for Kakamega County. So this was not was deemed not possible by His Excellency the Governor, because he argued he cannot receive money and take it back. And that led to us being forced to go ahead on our own. So we went through many challenges, and a lot of advice here and there came up with policies, which now again were approved through the county assembly, and we were able to start off. The subsequent year, that's 2016, 2017, the money came down a bit, but we were able to get good donor chairs and donor stations. We purchased a cryocentrifuge, which I'll show pictures, and supported all the other activities. And what happened is the county posted staff, 8 staff in all cadres, 2 nurses, 6 technologists, 1 driver, and 1 support staff who will do the cleaning and arrangement of commodities. We went through the usual county budget lobbying, and in the financial year 2017-2018, blood transfusion services in Kakamega was officially established as a program under the Office of the County Director of Health. So we have a guaranteed 15 million to support blood transfusion each year. Whether I do a proposal or not, each year we get 15 million, including the one you are in, and next year. So proposal for next year, we have proposed to purchase a fully automated machine, and also improve our annual budget to 18. Remember, our ideal budget is 42 million for us to serve the population we're in. So we actually get only 28.9% of our budget, but we thank the county for that, because being the medical superintendent for the facility is also support of blood, and we are almost guaranteed of having an additional 1 million per month from the Kakamega County General Hospital. So this vote is usually consumed through respective departments. If it's reagents, we request through the lab in charge for the county. If it's refreshments, it's the nutritionist. Supplies, we go to the commodity nurse, but on calculation, it comes to 1 million per month. So that pushes our budget to almost 25, 27 million, just dedicated towards blood transfusion service. So for us, we think this is quite some effort from the county. Next. Yeah, so our factors of our success: 1, we have visionary leadership right from the start. The governor, the CEC, the 1st, 2nd, 3rd, and even the 4th, they all realize the importance of blood transfusion. Because if you look at our data, 85% of referrals to the CGH is actually blood transfusion. Either a child has severe anemia requiring transfusion, a mother with a retained placenta. So even as systemic intervention, it is wise for the MedSoup to support blood transfusion, so that once there's enough blood, instead of the mother coming with the challenges of relocating an anemic mother, you rather dispatch a vehicle and take blood to the facility. So we do reverse referral, even from the hospital. So all our leaders support blood transfusion. 2, we all know behind each successful man, there is a hardworking woman. Her Excellency Ms. Oparanya is the patron for blood transfusion, and she's a champion for blood. I've just seen her off. We visited our site today. That's Sigalagala National Polytechnic. where she came to officiate today's version of the World Blood Donor Week. And she has really helped us mobilizing resources, securing venues like in the markets, churches, women groups. So she really helps us. Three, I'm lucky to have very dedicated staff, and majority are young and innovative. If you look at KNBGS data, I think almost 87% of blood donors are below 25. So being over 40, probably I cannot connect with these donors. So what I've done as a leader, mine is mainly to provide resource, but in terms of operations, planning, reaching out, coming up with innovative techniques like hiring DJs, music, road shows, I leave it to them. All I do is give them the resource and give them a target, and many times they surpass it. Yeah, and they know how to connect to this critical mass of donors. Fourthly, transition and how transition panned out and devolution. I think with devolution, many people turned to the county government, and the donors will listen to the new system of governance, the MCAs, and this became a key resource in reaching out, lobbying for resources, like the MCAs through the County Assembly subcommittee on health. So all these people we had to reach out. We have organized two county-wide stakeholders, and the MCAs have come in, all school heads have come in, and all these were through the effort of the patron. So over time, you find that it was also easy to play along, because if MCAs could garner funds to go benchmark on irrigation in Rwanda, why not source for money in support of blood transfusion, of which many of our residents are dying? So that has been very key and was also part of the thinking that led to a guaranteed annual allocation of 15 million. We have an able partner in Rotary Club of Kakamega. We started slow with them, and they have a lot of connection with the universities, the Rotaract clubs, churches, especially the SDA. And these have really helped us during lean times when colleges and schools are out of session, and also branding and reaching out to the governor through informal meetings where they meet and they're able to push the agenda for blood transfusion. Through our director, he has really engaged the Ministry of Education, and this has given us unfettered access to schools. Even during Corona times, we have had letters written and scheduled to have talks on COVID, and be able to access schools even during these mean times. In our program, we have an important committee. We call it the County Steering Committee on Blood Transfusion. So our thinking was we should not struggle getting blood. We also need to give it back to the people. So one of the critics on blood availability, quality are the heads of facilities and administrators. So these people, we engage them through our monthly steering committee so that they become part of the solution. And also they have helped us in support, like in airtime, office materials, like the administrators for Mukumu Mission Hospital and St. Mary's. Through their bishop, they were able to reach out to their colleges and also the Catholic schools. And through that, we had a foothold in their schools under their leadership. Next. So our budget, we prepare budget proposals each year, submit before March of the financial year. Like now we have already submitted our budget proposals for next financial year, prepared a procurement plan and input in the countywide procurement plan so that it can be captured in the IFMIS for those who are in administration. And also we have the annual work plan. And votes include reagents, What is interesting about reagents, we're able to convince the county that at the beginning of the financial year, we pay for the entire amount. If we want reagents for 8 million, we pay upfront, have an agreement, a standing order agreement with the merchant so that they supply us with an agreed quantity, be it 3 kits per month or 4 kits, depending on our collections, so that at no time do we find that we have stockouts, because once you've paid, they have an agreement with the manufacturer, and it is captured in their monthly stock level. So at all times, reagents we should always be having, and it has been quite successful, especially the first 2 years, because they ran us through 2 years and they never failed. So this was an agreement advised by the county attorney and sanctioned by the CEC and the governor. And we were in paradise for the first 2 years. We also have votes in equipment, consumables, donor refreshments, printing and advocacy. Like today we have nice banners, we have t-shirts even for mobilizers. The First Lady came in a beautiful t-shirt, and for us, that is branding, telling people we exist and we need their blood. We also have, I always budget for service of equipment, all our equipments, including the fans, the fridges. We prescribe EQA for reagents. We have some budget on training, office operations, fuel and vehicle maintenance, and daily subsistence. I've mentioned that we get support from Kakamega County General Hospital, non-GOK facilities in Kakamega and Kisumu, notably Mukumu Mission, Kakamega Orthopedic Hospital, Avenue Hospital in Kisumu, and Aga Khan Hospital. They give it in refreshments and drinks, because like Avenue may require 2 pints of blood, and they bring me 4 crates, which when I go to a school, I'll get 100 pints. So at the end of the day, we help them, and we also get the blood. And one of the things we have had to demystify is giving blood to private facilities. And my thinking is that they are Kenyans. Personally, when I'm unwell, I don't go to a GOK facility. And should I require blood? That request does not come in the name of Mchana. 2, we have had an incidence of a headmistress who was admitted in a faith-based facility. She gives us access to her school, and she was denied blood during the Kakamega satellite era. Of course, in the next visit, she chased us away. So, I mean, we get blood using taxpayers. The people who go to the private facilities also tax the Kenyans or human beings. So we have had a very liberal way of engaging these people and transform them into partners where it has really worked. Next. Yeah, so emerging developments is the clamor for counties to have adequate blood supplies. I think I don't need to overemphasize this point. All the counties you go to, we've had people come as far as Eldoret, Nakuru, Siaya. I was here the other day just to benchmark, because everyone feels the pinch of not having adequate blood. And for this, I think we had a head start, and we can only thank God we started early, because it has helped us be in control. And in the 5th annual devolution conference, when the governor was asked to pick 3 success stories, then out of the 3 major projects, number 2 was blood. After the level 6 facility, which is setting up, number 2, he felt blood was something good. And I remember the Senate committee led by Honorable Amos Wako actually asked us if they want to come up with any policy on blood. Probably they'll come and benchmark on what you have done. So as early as 2018, the populace could see that it was helping us meet our blood challenges. We have participated in national audits on blood transfusion. There's one which was done by the Office of the Auditor General, and we received very encouraging support and recommendation through those audits. And I'll want to say openly that I've seen KNBTS being revamped, and I'm happy to be part of the bigger picture where blood is a network. You can have 100 pints, but you don't have a single specific blood group that's required, so that someone in Mandera should feel reassured they can access safe blood from Kakamega. I look forward to the KNBTS bill, because we also have other big dreams in Kakamega, and I think this bill captures they capture fields beyond blood transfusion because of the stem cell and the organ donation. So I'm really hoping it can become an act as soon as yesterday. Next, Doc. So I think for us and my team, which I head, the KNBTS bill is a very good bill. Why I think it is, I'm thinking if Kakamega can marshal 15 million per year, and we have a vehicle, we have staff, that's less pressure for the overall goal of providing adequate blood for this country. So assume 40 counties can marshal 10 million just to support blood. That's 400 million. I think, I don't know the annual budget for KNBTS for them to provide 400,000 pints. But I think that will go a long way to relieve some of the financial constraints that all of us find ourselves in. So for me, if we can use the Kakamega model and have this money from the counties, and then through KNBTS stewardship, we come up with a good way of supporting blood transfusion. I think it is a welcome start. And regional cooperation and improved collaboration, formation and identification blood transfusion officer. Sorry, my net went down a bit. So the county blood transfusion officer is a welcome start, and since 10 days, I think, or so, it is helping us put our thoughts together and also borrow experiences from other regions as we endeavor to provide enough blood. Partnerships are very important, be it from the corporate world, the NGOs, multi-partners, all these people are very welcome. Innovations and technology, these are very good. We know about the Damu Sasa and any other form of innovations, and they may not be so advanced, like some of the things which you have had, like in Kakamega, where I felt I didn't have enough staff and getting staff was difficult. So what you do is just look for money for allowances, so it becomes locum. So when you want to create two teams, you have trained technologists and nurses. So the ones who are off duty, they come and become part of the team, and you pay them locum, and you'll not feel the staff shortage when you're going for the field. So simple things go a long way to help us. Next. Sorry. So this is our center. This is the one which we renovated. Actually, it was an old X-ray built in 1949. So it still has the dark corridors where they used to develop the films, but inside it looks better than it looks outside. And that's the vehicle, a new Toyota double cabin, which we bought in this last financial year through the Transforming Health Services. So when you look at some of these programs, they have a strong component on blood safety and blood transfusion. So if you lobby, you can get, and this year I'm hoping to get a van. We have already gotten quotations from Toyota Kenya. We want to buy a 17-seater Toyota Hiace, which they'll modify and put speakers so that it has the public address. The young men can come in with some music and they project it and be able to attract the more willing donors in our population. I think that would be my last slide. Thank you, Dr.
Thank you so much, Dr. Mchana. I would request the rest of my panelists to perhaps just clap for Dr. Mchana and the amazing work they are doing in Kakamega County. Please, colleagues, let's just clap and just acknowledge the amount of work that has gone into making sure that blood is available in Kakamega County. Thank you so much, Dr. And we are grateful to the whole team.
And thank you for your leadership.
Thank you, Dr. Mchana, for saying that. Even I was looking at your presentation and just wondering, where is KNVTS in all that? I'm sure we've collaborated many a times. You have helped us with reagents. We have helped you with reagents as well. True. And you have actually done testing for quite a number of counties in that region, especially when we used to have the stockouts. Now we are glad to say we no longer have reagent stockouts. So even the blood that is being collected during the World Blood Donor Week will actually be tested and be shared to everybody in a timely manner. So all clinicians, please continue requesting for blood from from the collection centers. So we come to the end of the presentations, the formal presentations. We have about 10 minutes to take some questions. I'll request my colleagues who will be in on this particular webinar to answer some of the questions that are in the Q&A. I will be reading them, and as I just ask some of you to respond to them. The first one I saw was, perhaps Peter can take this one. This was from Sylvia Mwathi. What are some of the contraindications to blood donation? Are medics allowed to donate? And also there was another one about, is it possible to give malaria prophylaxis or recipients of blood and blood products?
Yeah. Okay, so maybe let's start. So who should not give blood, right? I think you should start thinking about people, for example, of course, people who have infectious diseases like HIV should not give blood, even though if they are under treatment and hopefully are undetectable, but they should not provide blood transfusions because there still is a chance of transmitting. And of course, those would be captured because they will still have antibodies. But however, I think a more important group is also people who have, for example, low hemoglobin levels, so iron levels, blood iron levels. They should not give blood. People generally having cardiovascular issues, I mean, they should not give. People with chronic diseases, they shouldn't give blood. So basically, if you want to donate, you should be healthy. I think it's the first. This is kind of the way you can also look at it. The other one, if medics can give blood, I think yes, there is no limitation what your professional background is. Again, if you're probably at a background, if you have maybe that's then more the general remark, right? If you are in a situation where you are exposed and of an increased risk of acquiring an infectious disease, then you may not be eligible as a blood donor. So that can, of course, be being a medic, being a nurse, being an HCP, right? So that's maybe more an individual choice. So, but being a doctor, being a pharmacist, being a nurse does not exclude you per se of giving blood. I think it was, and the third question was about malaria treatments. I would maybe somebody else in the group can answer that more precisely. I'm not aware of any contraindications. But then again, if you are on malaria, so it depends really. If you're just using it as malaria prophylaxis, then it should not be a problem. So I would need to double check. But of course, if you're using it to treat malaria, then you should not give blood.
Okay. So
Right.
about the malaria, we previously used to give malaria prophylaxis. Then it was seen that malaria was not actually across the country, but in malaria endemic areas, it is it's a common practice. But in areas where it's not endemic, there's no need to give the malaria. Treat malaria if it comes. Okay. So thank you very much for that. Perhaps we can get another round of questions from the questions box I'm seeing here. A case whereby a person is a regular blood donor and maybe one time in life will need blood. Do they need to pay for the blood? Dr. Mchana, please. And also there was an issue about somebody who used to be a regular blood donor, was given a wrong test. He had to go and confirm in a different facility, then became irregular blood donor. Can you respond to that or just speak about that?
Yeah, okay. One of the challenges we had when we fully now became almost autonomous is the public perception of blood transfusion. The issue of blood being sold, someone died yet their kin donated blood. So we have had to come up with, I may be able to share A to Z about blood transfusion, which captures many of these complaints, and then we answer them professionally. So we have become very professional. Even among our staff, they had different sections: donor mobilization, donor care. We have nurses who are now well versed in blood transfusion, so that they handle it in a humane way, professional way, and they answer all these queries. But more important, we have steps to confirm these results when they're feeding into the donor card and we're going out to distribute. We make sure that they're done, and over time we won over these purported ills of the past. But before, I think when I came to Kakamega, the unit was being run in a way which would turn off a serious donor.
Okay. Thank you, Daktari. There was one about conflict of interest between Damusasa, Life Bank. Who wants to answer, Life Bank or Damusasa?
I think I can take it up. I can take it up, then Philip can probably add in some more.
Yeah,
first and foremost is that we in Damusasa, and I'm happy to note that those in Life Bank as well, do not see it that way. We do not see each other as opposing factors. And we actually had an interesting conversation yesterday on Monday during the launch of the World Blood Donor Day, Philip and I, and it was quite amusing to us that people actually do view us as opposing factors, but that is not the case. Personally, I actually think we have different strengths, and one of the key things we took it upon ourselves, both Life Bank and Damusasa, to do is see how we can bring those strengths together in order to actually be more effective as a joint unit. Perhaps I'll leave it out to Philip now.
Yeah, I think Aaron has said it all. I think for us, we are not competing factors. Basically, what we've come to realize is that we have different complementing factors within our businesses that can be able to make sure that the partnership I was talking about earlier on are quite actualized, and making sure that all of us can be able to just save a life using our technology and all our systems. So for me, I can say that both of us are quite different in terms of how we operate, but we bring our diversity to make sure that that diversity can be able to sort out problems that are currently affecting the ecosystem. So for us, we coexist well, and we don't see any form of competition, and we will continue working together to make sure that this happens. I know most people think us having a donor app and them having also an app makes it competition, but no. What happens is this: if both of us can be able to rally and make sure that donors can come and donate, I think that would be the best thing ever, because they can get 20 million people, we can get 10 million people, and bring those 30 million people together donating blood will be the best thing for this country. Thank you very much, Dr. Chek.
Okay, thank you so much, Philip, for that. I see a question: which drug do you give for malaria prophylaxis on transfusion? Is it full AL dose? And I've also seen Jesse Gidanga asking the issue about treating malaria when it occurs can be tricky, especially when considering very sick patients, e.g. the neonates, immunosuppressed patients. Why doesn't the blood transfusion service not consider testing for malaria? These are all important questions that we are asking. With our limited resources, we are currently doing the five minimum the tested TTIs, and actually malaria is one of the other ones we want to include in our panel come the next financial year, and we are currently just trying to see how we can make that possible, especially in the endemic areas, that is in the Kisumu RBTC, in the Mombasa RBTC, as a start as we continue scaling it up. So yes, we do have that in terms of like our projection. I'd like to ask somebody from the audience to ask one question. We have about 3 minutes, and I see Patricia Moiroje, if you are able. If you can, perhaps Wenda, we can unmute her and she can ask her question live.
There's an anonymous question there.
Yes, go ahead, Dr. Take it.
That now that our big support is through the governor and the first lady. So I mentioned that from 2017, we are now guaranteed of 15. It's a program under the office of the director. So that 15 million annually is guaranteed even when the next governor comes in.
Oh.
Okay, there's this question of whether blood transfusion is free. Okay, my work is to provide adequate safe blood to the facilities. And what I understand, the facilities, the one in public, they charge for grouping and cross-matching. So usually it's around 600 shillings. But I know private facilities like Aga Khan, they usually repeat the tests, though they communicate the results to us. So they repeat that because of they want to take responsibility should something arise through the transfusion. So that adds an extra cost to them. But in GOK, it's just the grouping and cross-matching.
Okay. Thank you, Dr. Patricia, please go ahead. We have 1 minute to hear your question and answer it. Patricia, are you able to talk? Okay, go ahead. Okay. Then I guess we take from the chat box. I see somebody, Evelyn, is asking about the eligibility of donation. It's between 16 years to 65 years. If you do not have any contraindications, that is, you're not on any other therapy, especially I saw another question about immunosuppression, immunosuppressive states, people who have been given like organ transplant, undergone organ transplantation, are on the immunosuppressive medication. Those are not eligible to donate, but anyone else can donate. So once again, we are at the 4 o'clock mark, and that is how long we had here today. I am truly grateful that all of you, most of us, if not all of us, will become regular blood donors and actually will participate in the World Blood Donor Week. We have this activity going on across the country right up to Saturday. Some flyers are already circulating in social media. Please join or visit your nearest blood donation center and be able to save a life today. Thank you all for joining in, and enjoy your evening. Thank you.